discussion of my favorite topics, which is the management of ocular surface squamous lesions. And today I'll be talking about squamous neoplasia. And I do see many tumors every day. I promise my visitors at least 10 tumors a day. And if anyone is able to visit when Miami is clear of this being the epicenter of COVID, you are most welcome to come and share in my enthusiasm. So I have no financial interests to disclose, but I will be discussing off-label use of approved medications. And I have a wonderful team of researchers and fellows that help me with what I do, and just wonderful colleagues. And I thank you all so much for having me here today. So we're going to start with a case, a patient. He was 95 years old, and this is what his eye looked like. And we'll say, well, what can we say about this particular lesion? So one, I would say, okay, it is in the exposure zone. There's some feeder vessels, and it really has a very gelatinous appearance, mostly over the cornea in this case, but emanating from the limbus. So what is this? Is this a pannus? Is this a degeneration? This is a classic appearance of ocular surface squamous neoplasia. And then the question is, so what are we going to do with it? So the first traditional management of this would be to do surgery. And if we're doing surgery, that means I have to take out the tumor, but I also have to take a margin of clear tissue that I'm going to be removing 360 degrees of every limbal stem cell, ending up with stem cell deficiency, and then calling on my dear colleague and friend, Dr. Guillermo Amezcua, to help rehabilitate the ocular surface. So I have some medical options, and that is for interferon, which in India you know very much about, and I have used a lot here in the US, which we'll talk about, 5-fluorouracil and mitomycin. There's some other drugs, but these are the main 4 options that we have to manage this tumor. So let's just take a step back and talk a little bit about what is OSSN, or ocular surface squamous neoplasia. And this is the umbrella term that we use to describe mild dysplasia of the cornea or the conjunctiva, to intraepithelial neoplasia, to invasive squamous cell carcinoma. And it has different appearances. Sometimes it can have this an obvious mass. Sometimes it can be a little more subtle. Sometimes it's more opalescent on the cornea. And the main risk factors, number 1, 2, and 3, are sun, UV, but also human papillomavirus and immunosuppression play an important role in the development of this lesion. What we're going to talk about with the next lecture, but I do want to mention now because it helps with every patient that I see, what is new and exciting, in addition to topical medication and chemotherapy, is the use of high-resolution OCT that lets me see what is going on within these masses on the ocular surface. I use it to help me diagnose what's going on, but also to help me follow the patient with medical therapy to make sure it's gone, and to check for any early recurrences. And in addition, in settings of complex ocular surface disease that we're going to be talking about later today, it's also very helpful to identify areas of neoplasia that clinically may be difficult to see in an eye that has other confounding factors. So let's look at an OCT, and this is the OCT of that 95-year-old that I just described. And when I look at an OCT, which we'll talk about more in the next lecture, I first look for the normal epithelium, which here you see is dark and thin on the right part of the screen over the cornea here. And then you see a very thickened hyperreflective epithelium that's marked with the asterisk. And here you see some shadowing, but you can see that there's a nice border and demarcation between the tumor and the underlying tissue. Sometimes you can't see that, but in this case, we can see that it's right on top of the cornea. So there you see the normal, the thickened hyperreflective epithelium. And this abrupt transition is what you see in histopathology and is mirrored by the morphology that you see on the OCT. And these are classic findings for OSSN. So next we're going to talk about more our treatment options. As we said, surgery. The great thing about surgery is that it's over fast, unless there's, of course, recurrences. It's covered by insurance here in the States. The problem is it's hard to ensure that you've gotten every morsel of the tumor off. You do your best guess as a surgeon to try to hopefully clear any visible tumor, but you can't guarantee that you're going to get every little seed. And as I mentioned, extensive excisions, like in this 95-year-old who has tumor all over his eye, end up causing stem cell deficiency, scarring, diplopia. So the medications that we briefly mentioned, they have the great advantage of treating the entire ocular surface. So when the patient takes the drop, it goes all over. So you don't have to be a magician knowing where it is and where it isn't, because the medication goes all over and it helps them treat the subclinical disease, microscopic disease. And the options we are going to talk about, we already said. The downside is that it does take time and it does take compliance and out-of-pocket costs in the state. I'm not sure in India if this is covered for the patients or not, but our patients do have to pay out-of-pocket for it. And some of the medications do have some side effects, mostly the 5-FU and mitomycin. So our patient comes in and the first thing he says to me is that my doctor said that I have a cancer and that it's big. That is true. And then he said I need surgery immediately. And I'm 95 years old and I don't want surgery. So that's my dilemma basically every day is, do I do surgery on this patient or do I treat them medically? And then we're going to talk a little bit about the pros and cons and how I decide about what is going to be best for my patient. So when I'm faced with a primary or a recurrent lesion, if it's small, I think that either surgery or topical medication are going to work very well, and it depends on patient compliance issues and also the classic findings clinically to diagnose the OSSN or by high resolution OCT. Now, when a lesion is very large or annular meaning it goes all around the limbus, as in our patient here that's 95 years old, we know that surgery is going to cause stem cell deficiency. And in addition, that it's going to be potentially difficult to ensure that we're going to get clear margins. So in that scenario, I have a very strong preference for medical therapy. When I have recurrent lesions, meaning they've already had several pieces of their eye removed, or it's a deep lesion, then maybe surgical. And sometimes we need to combine therapies.